We're glad to have Dr. Magdy Milad with us from Northwestern University, here to talk about the debate he was involved in, and that was, should every woman have access to a high-volume gynecologic surgeon? Welcome.
Thank you for having me.
What is your take on this? What side?
Well, I really would rephrase the title as being every woman really deserves a high-volume surgeon. Undoubtedly, patients that undergo surgery from high-volume surgeons have better outcomes. They have less bladder injury, bowel injury, ureteral injury, less blood loss, shorter hospital stay, and even less frequent death. So it has a profound implication, and there's at least a dozen studies that have looked at this, including a meta-analysis consistent with my opinion.
What about the other side of things, the other side of the debate?
Sure, I think there's some thought about, is volume really the best marker of competency? And I agree, it isn't necessarily the end all,
Sure.
but volume is a measure, and it's a measure that's easily accessible. We have, there's databases that document how frequent physicians are operating and what types of cases they're doing, and so it's something that we can measure. But undoubtedly, competency is ultimately what we want to measure. We want to be able to say, yes, this person is competent to do this procedure outside of the operating room, and then we can potentially certify them for that procedure.
And what about access? A woman having an access to one of these? Is it hard to get maybe to one of those surgeons?
Sure, yeah. I think most urban centers, we have high-volume surgeons, high-volume hospitals with documented better outcomes, but undoubtedly there's an issue in rural areas, and I think we have to be very thoughtful about that. And it may turn out that we prepare a subset of OBGYN residents so that they can go out into those rural areas and really practice and be able to do complex cases with high volumes, to be able to maintain that competency. It's not about just like the initial training, but it's also about like the recency. When was the last time you did that type of case? And part of the issue for general OBGYNs that go into an urban center is that they don't do those complex cases for years. They may be, let's say, reasonably competent when they finish residency, but if it hasn't been 3 years before they've done a major complex gynecologic case, it's going to be very unfamiliar. The equipment, the procedure, the alternate plans, the equipment, I mean, it's going to be really challenging.
What about the implications for the patients, the physicians, and the specialty overall when women are sent to these high volume surgeons?
Well, the cat is already out of the bag, right? Patients already know. If they go to the web and they say, what should I ask my surgeon? Most consumer groups, most colleges and societies, even patient advocacy groups are already telling them, ask your doctor how many of these procedures they've done, what's their complication rate, what's the chance that I might be opened when the plan was to do this as a laparoscopy. So the implications are already there for the patient. With regards to access, yeah, it might be that they would involve another surgeon that has more experience or refer that patient, and the implications are that they may not be doing complex cases, and admittedly infrequently. From a specialty perspective, I think we are still struggling with, are we generalists, primary care physicians, or are we specialists? And as specialists, can we do the depth and breadth of practice, or are we going to be tracked? Will there be tracking associated with it? I mean, my practice is, I don't do 90% of OBGYN. I really do, I live in a very small subset. And I think that's true about most people who are reasonably good at things, is that they tend to do one thing really well.
In many specialties.
In just about anything, including outside of medicine. I mean, think about like electricians or plumbers, hairstylists, airplane pilots. I mean, they have a lot of hours doing one thing.
Your peers who listen to this debate, what do you want them to take away from this whole debate?
I think be self-reflective, be thoughtful. There is data that's consistent, ample data, that volume predicts outcomes. So be self-reflective about initial training, be self-reflective about recency, and when was the last time you did that, and be thoughtful about planning in advance, involving somebody that has experience, recent experience with that type of case.
Dr. Milad, thank you very much for your insight.
Pleasure.